patient who has chronic, severe suicide ideation, which sometimes gets more severe. And at those times, in my mind, always becomes the question of what's my emergency backup for this patient? This is a very bright, very educated patient. And the question is, what are my rapid interventions? I've been seeing this patient for a long time in psychotherapy, and the waves of suicide ideation are important to notice. Suicide ideation isn't just an event, it comes in different forms. And therefore, one is thinking about how do you treat it? Do I intervene now? How do I intervene? Do I intervene pharmacologically? Do I change my focus in psychotherapy? Do I call up their family? It is always a call to action. So ketamine is one of those tools which one now has. And of course, it's administered in particular clinics. I'm not trained in ketamine. I don't expect to train in ketamine, but I know people who are. So you have on your contact list your emergency call and emergency intervention settings. And ketamine has now become one of those for the question of acute, severe suicide ideation. So from that picture, let me mention the other tools we have, and then let me tell you the background, because the background will be different for many of you. When I think of the interventions for suicide, of course, dialectical behavioral therapy is our core kind of focus for the management and long-term treatment of suicide risk. But in addition, there are important areas of intervention for areas of depression and for the accompanying symptoms, in particular CBT. So how do you get to this topic? So the center which I direct for a long time now, the Center for the Study of Traumatic Stress, its focus is on disaster. That's the big umbrella of our center. So, but when you think of disaster, what does that include? Disaster includes war, which is a focus for our group in particular as part of our military medical center. It also includes post-traumatic stress disorder. It also includes stress effects on individuals. And much of our world of psychiatry is built around an event happens and our brain and the individual responds. And sometimes they respond with suicide ideation and suicide risk. So that's how we get to this topic, from the question of disaster to person meets environment to stress leads to brain and behavioral changes. We, everybody on this phone call, own the world of behavior change, not just mental disorder, but behavior change. Mental disorder is just one type of behavior change. There are lots of other behavior changes that we focus on. Do we have to call moral injury a psychiatric illness to notice it's a behavior change and becomes a focus for us? What about increased alcohol use? Not alcohol addiction, but increased alcohol use, which is a behavior change that leads to increased rates of family violence, increased motor vehicle accidents, increased risk for impulsive behaviors. So in the world of behavior change, understanding suicide ideation becomes particularly important. It also can lead to mortality and morbidity. So now moving in our curve, the arc of this curve, an important piece of public health, moving away from individual treatment and now think about your community and your nations, is what is changing across time in the world of mental health concerns and how those are public health issues. Coronavirus and COVID-19 has highlighted that issue. And one needs to think, I think there's an open mic, there we go. One needs to think about what are the trends in large groups across time as one thinks as mental health care providers, as well as how we treat our individual patients. One of those trends across time we know now has been increased experiences of loneliness, increased detachment, increased family violence. One of the trends in the United States has been increased rates of suicide. There have been increased rates of suicide documented in the past decade for the entire nation of the United States, and in particular in our armed forces. The military has been my primary focus, and so the data I'll talk about derives from studies of the U.S. Army. But the questions span, in fact, our entire nation and the globe. How to understand suicide risk, particularly do population level studies inform us about potential individual interventions. So, some background. In the U.S. Army, rates of suicide prior to the recent war that the United States has been engaged in were actually half that of the rest of the nation. Being in the Army was protective from suicide risk. Rates were about 12 per 100,000. During the past 2 decades, those rates have gone up more than double and have remained high. So the question has been, why is that? The example that Eric gave, which was very touching, of a 3-star general, in fact, coming to the American Psychiatric Association and saying, help me, I need your help. What's going on? Why are so many young people killing themselves? That remains an important question for us. So how do you address that question? How might one begin to say, where can one think about that? It's not just individual people, it's happening throughout a group. So to tackle a population level issue, one needs a series of studies. And why is that important? Because there is no one study that will answer that question. That the design of those studies need to be large data study as well as small case intensive control studies. And out of that came what's been called the STARRS study. That is the study within the Army that I've been involved with now for over 10 years, which is a compilation of studies and includes wonderful collaborators, in particular Ron Kessler at Harvard, Murray Steen at UC San Diego, and James Wagner at the University of Michigan. That has included bringing together large databases as well as intensive studies of individuals who are hospitalized for suicide and suicide attempt. So what have we learned, and how can that help broadly within the nation? By the way, I'll be talking on this topic at the Royal College of Psychiatrists in another couple of weeks. If any of you have access to that, there's a group of us talking about translation of military studies to civilian implications, particularly around questions of suicide, PTSD, and TBI. So what does one find? First, you find what's the right question. The right question is, who is at risk, when are they at risk, and where are they? And you have to answer all three of those if one's thinking population level: who, when, and where. So when one looks at the Army, and I'm going to focus in particular on suicide attempt, where we've had lots of findings of value. First off, the rates of suicide attempt rather than suicide, of course, the rates vastly exceed those of suicide. The rates of suicide in the Army are running around 28 per 100,000. The rates of suicide attempt are perhaps 15 times that. So the ability to study suicide attempt, is also much more possible. Secondly, in the United States, there are more suicide attempts than there are first heart attacks every year. When you tell that to a group of physicians, they say, "Are you kidding me?" And you say, "No, not at all. There are more suicide attempts than there are first heart attacks." It says that we need to be thinking more about risk outside of the heart in order to deal with the morbidity of a nation. So what else? What's the rate of suicide ideation? In the Army, about 12% lifetime. Guess what? It's about what the nation is. About 12% of the population has thoughts about suicide ideation. What's the rate of suicide attempt? About 2 to 4%, actually, of people have attempted suicide throughout their lifetime in the nation. And that's also true in the Army. It's a strikingly high number. If you ask how many people in the Army, and you could ask the same thing the nation, have a parent who attempted suicide, it's a remarkable figure of around 3 to 5% have a parent who attempted suicide. There's a study which has just come out, which we did, again, in one of our military populations, to show not unexpectedly to a group of clinicians that we have here, the risk associated with having a parent as having had a suicide attempt. In fact, the risk doubles even after you control for the mental disorders of the individual, as well as self-reported by the individual mental disorders in the parent. So parental suicide is a risk factor. And of course, we know that includes both biological as well as environmental and psychological components. Well, what do we know about how suicide risk might spread in a group? Do we know anything about how suicide attempts cluster? There actually have been very few well-done studies that have to do with suicide clusters, but we did one in the Army, which offered unique opportunities of looking across 10 years of data with deep, intensive data and diagnostic medical records available. And we could find that, in fact, yes, suicide attempts cluster in military units. You may be familiar with suicide clusters when they occur in a high school or when they occur in a community. And how does one intervene in a community when you see such a suicide cluster? I don't have the answer to that one. I wish I did. But we see suicide clusters. A military unit that's had one suicide attempt is at increased risk of another suicide attempt. And we see that regardless of the type of unit, and we see it regardless of the size of units. Notice that I'm talking about suicide clusters. Bing, bing, pearl moment. They aren't all contagious. We often, as mental health people, want to say, aha, it's an epidemic of suicide. Well, it is an epidemic, but how is it being spread? There are multiple ways in which you can spread a disease. In COVID, it spreads because of contagion, right? If someone has it, it passes from person to person. But it can also be that everybody's drinking from the same contaminated well, and it's not spreading from person to person, but actually there's one site from which the contagion is coming. And that can happen in a community and in a military unit. If you have a particular area in which the stress is high, you have a toxic leader, you have people facing similar stressors in their life, you can see a cluster that occurs because they're all in this same group, which is experiencing high stress with bad leadership and bad caring. So when one sees a suicide cluster or suicide attempt cluster, remember it's a cluster. It's not necessarily a contagion. You have to go and check that out. Well, what else have we learned? Another factor that we look at is the when, right? I said who, by the way, are usually young people early in the military in our population. But when are they at risk? Many people talk about increased risk related to deployment in the military. In fact, we find that although suicide rates went up among deployed soldiers, suicide attempt rates actually were lower compared to those who had never deployed and those post-deployed. So is that the whole story? That's where you stop? You say, in fact, suicide attempt rates are lower. Let's say I said suicide attempt rates are lower in your community than the one next door. Well, how about the question of when do they occur? Just because they are lower doesn't mean it isn't of importance. One of the things we were able to do in our military sample is ask when during a deployment is the risk highest? Just as you could ask in your community, at what age is the risk highest, even if you have a low rate. And then you can begin to target those people and think about what care is available for them. In our study, we found that, in fact, risk for suicide attempt was highest in mid-deployment, about halfway through. So there's a curve that goes up and then comes down. Lots of reasons to think about that. But the important issue here is this question of when. Who is at risk? When are they at risk? Now the question of where. So is it the high school that's downtown? Is it the high school in the community? Is it the subsection of your city? Where are these people that are in fact experiencing suicide? Is it those who are in fact involved with opiates, as we've seen an opiate epidemic in the United States in terms of deaths? Your interventions will be substantially different. Well, we looked at what are the different occupations, and we found that, in fact, one of the highest occupations of risk was actually medical corpsmen. So those who train to be medics. And then we could look in that group to find when is their risk, and it turns out to be while they are in training. So now by who, when, we can also determine where, because we know where they train, and we can think of interventions. So let me bring up one last area perhaps and then pause a bit. We know in the big world of medicine, which I live in the United States, and many of you live in your nations, we're talking a lot about what we call precision medicine, precision health. Not, I would say, personalized medicine, because we really aren't personalized. But precision medicine highlights a perhaps not so well known but obvious secret in medicine, that actually in medical care, we don't treat disease. What we do is we treat a group of people that we think may be at risk of disease. So let me give you an example. From the faces I see, many of you are way too young to be on statins for elevated cholesterol, although I see a few faces there that match mine. Certainly your parents or grandparents and others will have been placed on statins. How do you make a decision? How does your doctor make a decision to place someone on a statin for elevated cholesterol treatment? Well, there's an algorithm they use, right? An equation. Truly, you can find it on the web. And you put in what's the person's blood pressure, what's their cholesterol, what's their family history, a few other factors. And out of that comes yes, no. Put the person on a statin or don't. Now, what is that equation actually doing? That equation chooses the 7.5 people out of 100, 7.5%, meaning everybody who was told yes or falling in that group. 7.5 people out of 100 will be at increased risk of a cardiovascular event over the next 10 years. 7.5. But we put 100 people on the statin. And in that group, only 7.5 are actually going to have a bad outcome. The equation says, put these 100 people on the drug. And why are we doing that? To help the 7.5 people that are actually going to have an event happen. We give it to a large number of people, knowing that we're only going to help a few actually in that group. But what we give is a drug that has low side effects and high efficacy. So the yes-no identifies the group of 100 people at risk, out of which we know we're only going to help 7.5. So where are we in mental health with this? And this is where some of our work has become nationally important. Our collaborator, Ron Kessler, really headed up this piece of the work, which was to say, when is the highest risk for suicide? The highest risk for suicide is post-hospitalization for a mental health disorder. Can we predict what group will be at highest risk when they are discharged? You got to identify what group to target. You can't intervene with everybody who's post-psychiatric hospitalization. So we developed an appropriate algorithm, which can in fact identify the group of 100 people at highest risk after a hospital, after having been hospitalized psychiatrically. In that group, 4 people will be dead in a year. Not 7.5 having a cardiovascular event over 10 years, but in this group of highest risk, 4 will be dead in a year. So we want to do something to help that 100 people, because we can't target specifically the 4, but we know they're in that group of 100 at highest risk. What's our problem? Our problem in mental health is we don't have a statin. We don't have something we can give to 100 people that has very low side effects, is cost effective, and is highly effective as an intervention. We need more statins into our mental health armamentarium. It's way too many people to give everybody CBT. Now, there are some interventions that have been talked about and tried. One you should be alert to is called caring letters. And the data is, I would say, 60% positive and 40% not, meaning we need more studies. Caring letters are actually letters sent to everybody post-psychiatric hospitalization. And they are a letter that says, we're thinking about you. Don't forget your appointment that's coming up. We look forward to seeing you. If you need to talk to us now, give us a call. And everybody gets that letter, maybe once a week, every 10 days, to remind them. And the letters are different. They're signed by important people at the hospital and sometimes by the physician or the mental health care provider who provided care. And there's data to show that just by providing such caring letters, one can decrease the rate of suicide over time. Caring letters may be, in fact, a population level intervention. And returning to our direct clinical care, caring about our patients is, in fact, the most important intervention we have for suicide risk. When we talk about the therapist-patient relationship, the strength of that relationship, frequently built on what we call suicide risk contracts, euphemism, I believe, which is to, if you're going to get upset and think about committing suicide, please call me. And we frequently bring that up with the patient. Why does that contract work? It's not because they signed a contract. You're not going to sue them if they break the contract. It's because of your relationship with them. It's because of how well they care about you and you care about them. That remains our most important intervention for the prevention of suicide. Perhaps at the population level, certainly true at the individual level. I'll stop there, Eric. Thank you all. It's been a pleasure to talk to you.
Wow, dear participants, what we've just heard, if I may say, has been such an eminent wisdom, and this was such an enormous pleasure to listen to you, and the breadth of going from waves to behavioral change to trends to rates to the who, when, and where, the clusters, the precision medicine, the case of statin and the caring letters. That was a beautiful array of expertise. And now, well, if somebody has the courage to ask a question, go to the microphone open, and Bob is with us to address them. We may go a little bit over the hour, over the bottom of the hour, I should say, though. if that is okay with you, Bob, to spend some time with us.
Sure.
If anybody wants to speak, then open your mic. And Irina, I cannot see the chat, but you may be able to see. And if you just wanted to
I
comment or say, just say where you're from, and then address the question, please.
I can see the chat. It's okay.
Please.
Thank you, Professor Ursano. And constantly, I was thinking about the situation with the Ukrainian military and the studies we did since the armed conflict started in Ukraine. And the main issue was that we were not prepared that the rate, not just suicide, but the drug and alcohol abuse would increase so much. And I'm sure there are correlation between those factors, but maybe you can comment on that as well. Thank you.
Right. Right. So a couple of perspectives. Um, the increased rates of drug abuse and alcohol abuse are highly related to their availability. Um, and so let me give you the experiment. The experiment was during Vietnam in terms of the US military. During the Vietnam War, we saw tremendously increased rates of opiate derived addictions. Um, and a huge piece of that was they were so widely available on the corner, walk outside, pay a minimal amount of money, and have it available. Another piece of that we saw, which was most important, there was a huge debate in the United States at that time about we've created a group of opiate addicts. However, what we saw is when soldiers came back, they gave up their opiates, which was totally unexpected. Some marvelous studies done by Lee Robbins. And it highlights the importance of context, the contextual issues of addiction. Now, the second piece of that story is a COVID story. During the period of COVID right now, particularly in one state, West Virginia, but across the nation, we've seen substantially increased rates of heroin overdoses and opiate overdoses. The availability has been high, and the increased sense of loneliness has been high. And in that setting, we've seen increased use and, of course, mortality associated with it as well. Alcohol is an ongoing problem in our military populations. They represent our young folks. Alcohol is the highest, most readily available of any of our hallucinogens that can be used. And it usually shows up as binge drinking. And I would encourage any of you looking for a career to examine several things if you're in the research world. One is binge drinking in particular, how to intervene, how to treat, and which populations are at risk specifically of binge drinking. And the other is adjustment disorder, one of the unlooked at psychiatric illnesses that comprise so much of our actual practices and highlight the issue of event and stress response. And yet we know so little about what is an adjustment disorder. So coming back to your question, Irina, which is great, we have an adjustment disorder that's accompanied with available drugs and available alcohol, and they come together. So the story sounds familiar.
Thank you.
Thank you, Bob. There is now a literature about PUI, problematic use of internet, and suicide. Kind of, that it is somehow associated with this. Any comments, any thoughts about this?
Yeah, so there's two areas. One is this question of loneliness. So there are a couple of nice studies out about changes in loneliness. Loneliness is a very interesting phrase, very interesting experience, because it's an interpersonal word. It's not an emotion word, it's an interpersonal world one feels lonely, which says something about who you are with or who you are not with. We know that loneliness and isolation increases suicide, and loneliness and isolation are accompanied by increased internet use. That's how I got there. It'd be great to understand more about loneliness and more about a concept called mattering. Mattering is, who do you matter to? Do you matter to anyone? Do you matter to a friend? Do you matter to a spouse? There's a literature on mattering. I like those concepts because, again, they're interpersonal, emotion in context. The other part of internet, which has become prominent, has been on two ends of the scale. One is there's been great interest, as you know, Joseph, in studying internet responses and when people are typing more at-risk words. And can we use the internet as a way to, in fact, intervene by identifying what the person is writing in their messages? And of course, the last part of internet is it's become a tremendous tool for delivery of care. CBT by internet absolutely works. There are so many studies on it. I wish we'd never do another one, but I'm involved in several of them. They keep multiplying in different populations. CBT delivered by internet, important. The other one is the treatment of insomnia delivered by internet, also tremendous in terms of its work. And why are these important? Because even if they have a smaller effect size, they're reaching thousands of people. So their effect at the population level is huge. When Coca-Cola, or choose your favorite beverage, makes a 1% change in their market, that brings in billions of dollars because it's a huge market. Same thing on these issues of population distributed care. Population distributed care is particularly important in the times of disaster and terrorism, in which one has populations at risk. And you try to get the biggest impact, even though it may not be as effective as individually delivered. So, wonderful tool that creates risk as well as opportunity, the internet.
Thank you, Bob. Any Q&As that you have seen arising in the chat that we
No, no,
maybe? No?
no.
Anybody who has? I see Ulrika on the screen, Ulrika Schmid, that we haven't seen in a long time. Maybe if I may give you the floor, Ulrika, if you just wanted to have a comment or so, if you wish.
Yeah, thank you, Eric. It's nice to be back in this forum. And yeah, it was two excellent talks we heard today. And I was also impressed of the letter of the what I would call suicide talk, because in the clinic I'm confronted with this topic every day, not only with PTSD patients, but in general. And what I learned is the word mattering, which I didn't know because I'm German, and I think it's hard to translate in German. And I think this is a very important point. And thank you, Professor Ursano, for mentioning this. I think this is very important, and we should take care for looking better to whom do our patients matter, and how can we increase this? How can we increase social contacts and so on? Thank you.
Maybe if I may, Bob, entering the pin here, we've all been in COVID for such a long time now. Why are we restricting our behavior? Because we here in the Netherlands, and I think globally, are preventing the hospitals for not being able to accept all the people who need to be admitted. Now you're just stating that the post hospitalization period is of a high probability of increased suicidality in the aftermath. Now we've seen hospitals flooded with people who are terrified for their health and probably for not making it. So we see a flurry of people that actually have been hospitalized for not just a day or two, but for a longer period of time. So anticipating that, is this sort of a wake-up call, like we need to send loads of letters of care to the people who have been hospitalized? Now, just a comment on this, please.
Yeah, great question. Of course, what I was referring to is psychiatric hospitalization, but you raise an important issue that hospitalization itself is usually experienced as some type of threat and increased worry about one's mortality and confronting what do I do with my life, either because of disabilities or worries and fears up ahead. The specific issues of suicide and COVID are yet to be told. We frequently see decreases in suicide during disasters and increases afterwards, so the specific issues remain. But I would remind, as I think you're alluding to, Eric, that we also see increased rates of suicide when people are diagnosed with complex chronic disorders. One of the pieces of the COVID story is what's called PASC, post-acute symptoms of COVID. And we now know that long-term COVID is very much on the forefront of trying to understand, particularly how it may affect our brain and cognitive issues that may endure for months, if not years. The importance of how those people respond will be particularly important to look at, as well as the complex issues associated with grief and the whole question of the treatment of grief, for which we now have specific interventions, and we have a diagnosis in our DSM-5, which is now prolonged grief disorder. It can be diagnosed after 12 months, and there are also leadership interventions for the management of grief, and we can look across the world and see where various leaders have dealt well or not so well with the question of helping at the population level for recovery from the grief associated with COVID. Great topic.
Yeah.
Thank you.
I think
just...
in the UK they have a ministry of loneliness, which I think it's a great idea.
Thank you. I was just trying to pin you in the closing of this session, Joseph, but now I cannot find you anymore. I would like to. Oh, maybe I can open it to the whole so that we can see a few people who are here. I would just maybe I will pin just for a second, just add a pin. Yeah, here we go. Here we go. I just wanted to end with this note of the four of us on screen. Maybe a few last words from Iryna and Joseph. And before I do so, I want to thank you, Bob, for, as I said, this was of high eminence and high wisdom, a lot of wisdom. I think this is the beauty of why we do this. We're still in COVID. We're sort of at the tail end. Hopefully, that we're all vaccinated, but we wanted to do this to give people the opportunity to listen, to hear wisdom and such insight as you have just shared with us.